Okay, let's make a start. I'm sure people will continue to dribble in from all over the world. I did see two people from New Zealand there already, so that's we haven't. It's only truly international if this Aotearoa is represented. So hello everyone. My name's John Reed. I'm amongst other things professor of clinical psychology at the University of East London, and in relation to today's meeting, I suppose the relevant thing is I'm chair of the International Institute for Psychiatric Drug Withdrawal, and I'm hosting the meeting. To say thank you, first of all, to James and Lucy for getting us all organised, and for Bob Whitaker, as always, for sort of being the inspirational figure in the background, without whom none of this would happen. So thanks, Bob. So we're here to discuss the use of psychiatric drugs with children, which of course involves the use of psychiatric diagnosis as well. And I just want to welcome you on behalf of the four organizations, Mad in America, A Disorder for Everyone, Council for Evidence-Based Psychiatry, and the International Institute for Psychiatric Drug Withdrawal. We're not going to be able to, while we're discussing those issues in broad terms, we're not going to be able to give individual advice around people's individual situations. It's just not appropriate for us to do so. However, there will be various resources posted in the chat, including a parent resources section on the Mad in America website, which we hope will be useful for you. Thank you all to those of you who have donated today. It's much appreciated, and that money will be put to very good use, we can assure you. I have to let you know that the session is being recorded, and your way to contribute to the discussion is to put questions into the chat, and Lucy will be keeping an eye on those and gathering them up for me to put as many as possible to the panel at the end. And I'm going to be very strict about the fact that we will reserve half an hour at the end to address your questions. So the agenda will be a brief introductions, about 5 minutes each, from each of our wonderful panelists, saying who they are, how they got into this, and what they're doing, but for about 5 minutes. And then we'll open the discussion up for the four of them to address some of the issues that we're going to be looking at today. Just checking that I've done everything that James told me I have to do. I think I have. Oh no, one last thing. I was going to just, no, I'll do that after introductions. Give you just a few brief stats, but I'll save that because it's enough for me for now. So over to the panelists to introduce themselves, about 5 minutes each. And if we could start with Mo, please. Welcome, Mo.
Well, thank you so much. And I am honored to be on a panel with such esteemed experts in this field. So thank you so much for inviting me. I want to just mention, I'm coming at this issue as kind of with multiple roles. I'm a psychologist living in the US, practicing in New York State. I'm a psychology professor. I teach at an undergraduate institution here, have for about 30 years. And I'm also a practicing psychotherapist. One thing I want to note is I was trained in biological psychiatry, okay, in the medical model of psychology. And this has something to do with my position with all of this that I hope will make clear. I was trained in the 90s, late 80s, 90s, and what came out in the 80s and 90s? The SSRIs, and then followed by, a little bit later on, the atypical antipsychotics. So this was the age of Prozac and Zoloft, and I was deeply embedded in that mentality that mental illnesses are caused by, as you well know, the chemical imbalance theory. I'm also coming at this as a former child and adolescent psychologist. I actually do see young adults. I see college students and I see young adults. I don't see young children anymore. I consider it a real subspecialty area that you kind of have to do all the time to do it well. But one of the things I want to emphasize is that I was deeply trained and I would say brainwashed in the safe and effective meme, okay? Safe and effective, as we all know, and we have all heard that. As an academic psychologist, I look at my abnormal psychology textbooks and they're still talking about the chemical imbalance theory, which is, I think, still the predominant model of treatment in many realms of psychiatry and even psychology. I want to share something that, actually a couple of personal experiences I had that radically changed not just my own orientation in this field, changing it away from that biological model to the social psychology model, or the sociocultural model, or the anti-psychiatry model, you might say. And those are some personal experiences I've had. And then I'm just going to piggyback on that and just mention a couple of things about my professional experiences working with clients. I had 4 children. I raised them as a single mother. And my oldest child, whose name was Monique, became depressed in the middle of her sophomore year at New York University, NYU, which, by the way, at the time she went, NYU was actually quite well known for a relatively high rate of students taking their own lives, their college students. Monique and I were very, very close. We discussed pretty much all issues with each other, including her mental health. She was a very complex, amazing young woman, very poetic and very artistic. She became depressed, as so many young people do in college in the middle of her sophomore year. And when she became depressed, I was still within the mindset of that biological model. As I said, I was brainwashed in that model, as I think pretty much everybody that goes through doctoral training in clinical psychology still to this day probably is. When she became depressed, my obvious inclination at that time was to turn to the mental health system. I myself was a part of the mental health system. And as you know, when you're a hammer, everything looks like a nail. And so my daughter, who at the time was 19, okay, so we're talking about youth, how did they approach her difficulties, her depression? Medications. And she went in and out of inpatient facilities. She went to probably a dozen different medical and mental health providers, all of whom had pretty much the same answer for her. There was very little emphasis on psychosocial treatment, on family therapy, on other kinds of non-drug related treatments. And the problem was these professionals were not seeing what I was seeing. And as she began to be prescribed psychiatric drugs, her condition did not get better, her condition got worse. And in fact, what ended up happening was, after she was prescribed things like mirtazapine, Lexapro, Prozac, a variety of other drugs, she became suicidal, and her suicidal ideation got worse and worse. I was the only one who could really see that. And she died at her own hand in April of 2007 at the age of 20. And this was despite my best efforts to get her the best help I possibly can. The best help I could possibly get her was the biological approach. And what should be noted is that in May of 2007, this is all something I realized in retrospect. I did not know it at the time. It's as though the paradigm I was seeing things through was that biological model I was trained in. But in May of 2007, a month after she died, the FDA changed the black box warning on antidepressants for suicidality in young people. It used to be that they were considered to be, a black box warning for children 19 and under. They raised it to the age of 24. How old was Monique when she passed? She was 20 years old. Too late for her. Too late for her. It was only years later that I realized that her death was probably at least partially due to the prescription of psychiatric drugs, because as we well know, one of the major problems with these drugs in young people, among many other problems, is that they can increase suicidality and increase other symptoms of mental illness. But I want to just mention another experience I had with a close relative, and this really is when the scales fell from my eyes. And this is a relative of mine who was placed on Lexapro, which is escitalopram. When she was 15 years old, for a variety of reasons, her pediatrician put it on her. She stayed on this medication, as so many young people do. They are parked on these medications for years. When she finished college, she said, I don't need this anymore. She was actually smart enough to wean herself off this drug. She was on 10 milligrams of escitalopram or Lexapro over the course of a year. So she took a very, very slow weaning approach, which is probably still too fast for 10 milligrams to go over a year. But nonetheless, she studied up and did not by any means cold turkey. Nonetheless, about 4 months after she ceased her last dose, she went into the most unbelievably horrible withdrawal state, something that taught me a life-changing lesson, the power that these drugs have on the brain and the devastating effects of withdrawal, which I know many people on this panel are experts at, but I saw this firsthand. She had every symptom in the book. If you look at the withdrawal symptom checklist, such as Dr. Glenn Mullins, she had extreme anxiety, extreme depression, suicidal ideation, total sleeplessness, total appetite loss, hostility, akathisia, listlessness, social withdrawal, paranoia. She was disabled by this condition for 30 months, 2.5 years of her young life. The good news is that she did recover, and she recovered completely. And if you want to know how she did that, I was assisting her throughout this period. It was through TLC, the passage of time, and most of all, keeping her away from doctors. And so these two...
It's my job to be rude, I'm afraid. I'm the rude one in the group. So can we come back to that, especially the the positive outcomes and how things can recover.
I'm essentially done. Thank you.
But there's going to be plenty of time to come back to that. That's very important. Thank you for all of that, Mo. That's a very sad story to hear. Can we move on to Elia? You're on mute at the moment, Elia.
Yes, sorry, you'd think after 1.5 years of the pandemic, I'd have learned by now. But thank you, John, and thank you, Mo, for sharing your story. I won't be too long because I think there's a lot of interesting discussion to be had. I'll just introduce myself quickly and maybe some initial thoughts on this issue and my experience with it. So I'm a psychiatrist based in Toronto, Canada. I see people across the age range, but I work primarily with children and adolescents. I have broad interests academically, but a big part of it is asking critical questions about some of our assumptions in psychiatry, be they related to diagnosis or treatment. And particularly, I've been particularly interested in the influence of the pharmaceutical industry and the way we see things, and diagnostically, but also in terms of the medications. But I've been more recently, over the years, interested more broadly in different kinds of biases. And where this comes from is since the past 6 years or so, 6.5 years now, about half of my clinical time is working in an inpatient unit in a hospital where I work primarily with adolescents in crisis and their families. And, the 6 years that I've been on this unit, it's not that long relatively, but yet even in this fairly short amount of time, I've witnessed, like so many have, a pretty dramatic rise in the numbers of adolescents who are struggling, having different kinds of emotional struggles. And I've been very concerned about this in terms of what's going on in our society. And I'm at the same time, I have to say, I've been intrigued by it and trying to understand it from a broad perspective. We see a lot of headlines all over the place about rise in adolescent depression, anxiety, rise in adolescent mental illness. But these terms, they trigger a very narrow biomedical kind of response that I think has been inadequate and even counterproductive. And I have to say, trying to think outside of that is challenging for many reasons that I'm sure we'll get into. But it's also rewarding. I've learned a lot from my patients and their families. It's funny because they, often they look to me for recommendations in terms of whether it's, parenting styles and such. And I find that I'm learning from them more than I've benefited as a parent from my work with these young people and their families. So I just want to end by saying that despite the challenge this involves, the challenge coming largely because these, Mo said she's embedded in the biomedical model. I think we all are. I am, and as a society we are, and trying to challenge that is very difficult on so many levels. But it's not impossible. I think, we can do a lot by working with people individually, but we also need to be thinking broadly about how we can influence things broadly. And I think, I've used the word challenging a lot. I think it's challenging. I also think it's rewarding at the same time. I'll stop for now. Thank you.
Thanks, Elia. Moving on to Laura.
Hi, everyone. I'm honored to be here. Thanks to the organizers for inviting me. My name is Laura Delano. I'm Executive Director of Inner Compass Initiative. We're a nonprofit organization based in the US, and our mission is to help people make more informed choices about taking and coming off psychiatric drugs, about psychiatric diagnoses, and really about the mental health system more broadly. I've also worked over the last decade in a consulting capacity with families and individuals who are trying to get off and heal from psychiatric drugs. And I come to this work from my own personal experiences. I spent about 14 years in the mental health system, beginning at the age of 13, and I left the mental health system. I came off the drugs. I discarded all the labels I'd picked up by then in 2010 when I was 27. And so my connection to this issue of medicating kids runs very deep. I was a kid when I was first sent to a therapist and then eventually sent to a psychiatrist who, in the span of our first session together, told me I had an incurable brain disease called bipolar disorder. And she put me on Depakote and Prozac at the time. And this was in 1997. And I now, all these years later, can look back and see, how perfect the timing was for me to get sucked into the system in this way. I was, of course, in adolescence. So I had some really intense, scary, painful, emotional experiences, really beginning around the time that I was 13. I was cutting myself. I was acting out at home. I was hitting my family and screaming and cursing and talking about how I didn't want to be here anymore. And I was just really disintegrated as myself was disintegrated. I can see now, life didn't make sense to me. I didn't understand these systems and structures that I was within, in school and in this town I grew up in, where it was upper middle class town, a lot of pressure and expectations. And so I really fell apart, and the timing lined up perfectly because in the mid 90s, there was a huge push to expand the category of bipolar disorder to include children, spearheaded by particular individual psychiatrists, one of them being a man named Joseph Biederman at Harvard Medical School, who kind of began to write and disseminate papers that were proposing that mania in children looks different than in adults. It's not, grandiosity and, rapid thoughts and whatever else. It's anger, irritability, outbursts. And so, of course, as a 14-year-old kid, that's what I was having. And then this despair I felt, and the fact that my life didn't make sense to me, was, that led me to cutting myself and just feeling so numb and hopeless and thinking about death. That got me the depressive side of that diagnosis. And so really, I was this kid who was presented with what I now see was an important existential opportunity to really find myself, to grapple with my place in the world, to figure out what I cared about, who I was, what mattered to me. And instead, I ended up getting sucked into the medical model. And of course, just as Mo said, my parents, they were believers in this model that our society is taught. They were doing what they believed was best. They were doing the best they could with the information they had. And because there were no other visible spaces for them to turn to for help with their struggling teenage daughter, they just concluded, we want to help her. When your child is struggling, you send her to a mental health professional. And, the rest is history. I got sucked into the system for a very long time. The diagnosis and eventual eventually multiple diagnoses just came to be who I was. The meaning of my life became being a patient and being a good patient and taking my meds as prescribed and talking regularly to my doctors, hours and hours of therapy. And never once did I step back to question, was this serving me? Was I actually feeling better? Was I actually evolving as a person? And I really wasn't. My life was falling more and more apart with each passing year until I eventually tried to kill myself as a 25-year-old because my life just didn't feel worth living, just this mentally ill existence with no way out. And so I feel really called to this cause because to be a kid and to be told by an intimidating professional adult who's a stranger to you that there's something fundamentally defective with your biology, and not just that, but that it will never be cured, is a profoundly degrading, dehumanizing experience. And I think, of course, the drugs that come with it affect every facet of a child's physical, sexual, creative, personal development in all these ways. And it's really important that parents and our society as a whole just get better informed about the consequences of doing this. And even more importantly, that we come together to create alternatives so that families actually have another option when they're overwhelmed and distressed. So I'm looking forward to this discussion today and to diving deeper into all of this with you. And again, I'm honored to be here. Thanks.
Thanks, Laura. So now we move back to my side of the Atlantic and over to Sami.
Hello, I'm Sami Timimi. I'm a child and adolescent psychiatrist based in the UK. Very humbled to hear particularly Mo and Laura's stories. And it's very distressing to hear that this is what's been happening. Somehow it seems a lot more distressing to think about the medicalization of childhood and growing up. Those vulnerable earlier years of your life. I've been in child psychiatry for quite a long time now. I first started in 1992 was my first job. So I've watched as things changed in the UK. In some ways, I consider myself a traditional child psychiatrist. In the first job that I did in child psychiatry back in 1992, in the whole 9 months, there was only one child that we put on any medication. We had a number of beds. This was based in a pediatric hospital where we had a few beds that we could use. This was in central London. And most of the work was around systemic thinking. And it really got me interested in child psychiatry because it seemed to offer an understanding that people develop. In other words, they change. So change is always there as a potential. And also that there is a system surrounding people. And that's particularly obvious when you talk about children who are growing up. And then I watched, as my career has unfolded, the gradual medicalization. In many ways, it's the Americanization of child psychiatry in this country. And there's been several points along the way that has that I've watched things begin to turn. And there has been a parallel growth in what I would call the typologies of categorizing different types of people into different typologies. And this growth of the typologies has been mirrored by a growth of this idea that if you can categorize children into a particular diagnostic, it's not a diagnostic category, it's a descriptive category. It's a pseudo-diagnostic category. If you can categorize children and their problems into these particular categories, you can follow it up with a particular specific treatment. And the more we allowed the influence of the drug companies in cahoots with academic psychiatry, which saw great opportunities for enhancing reputations and enhancing income, what we saw was a growth of medications coming into child psychiatry. And as I've watched this expansion, both in the numbers of young people who get diagnoses and in the numbers of young people who are being given individualized treatments, including psychotherapies and medications, with the idea that there is something going wrong in them that needs somehow correcting, what I've noticed is it ends up developing what I think of as a double alienation. First of all, it always has the potential to alienate people, young people, and their families from connecting their distress to all the different adversities that has happened in their lives. So anybody who works in a psychiatric clinic, including a child and adolescent psychiatric clinic, knows that the people that you see are disproportionately experiencing, for want of a better phrase, shit in their lives. So that's the first alienation that I see, is that disconnection. But there is another type of alienation that I find even more disturbing than that, which is a disconnection from your emotions and a fear of your emotional life, particularly your intense emotions. Growing up is tough, even if there are not a lot of bad things happening to you. And I think it's particularly tough in what I call our modern neoliberal compare and compete culture. And experiencing intense emotions is a part of that journey of growing up and learning how to deal with and how to withstand those emotions. You discover your natural resilience. But the more we label those experiences as being something that you shouldn't have, something that you should be able to suppress, something you should be able to control, and the more we connect that with taking medications for that purpose, I think it leads to a profound alienation. And one of the most difficult things for me as a practicing psychiatrist now is the number of people who very understandably present to me, or their parents present to me, with a concern that their young person has this or that diagnosis or needs this or that medication. And I'm sure we'll be talking about that further. Thank you.
Thank you, Sami. Thanks to all of you. A lot of sadness in those stories from people who've been through it on both sides of the table, so to speak. Anyway, before we move on to pick the brains of the panelists further, I just want to take no more than 2 minutes just to set the scene a little bit in terms of giving you a sense of the extent of the problem we are discussing. And I'm afraid that means boring you with just a few statistics, and I'll keep it to be as brief as possible. So currently in the United States, 10% of children, that's as defined by under 18, 10% are currently taking at least one psychiatric drug. And in terms of preschoolers, the figure is 3%. So 3% of all preschoolers are already on psychiatric drugs in the United States by the time they get to school. And we look at adolescents specifically, the figure is 12%. So 1 in 8 of adolescents in the USA are on one or more. Now, in the adult world, of course, the leading drug type is antidepressants, but in the child world, just statistically, as most of you will know, the leading drug type is for ADHD and stimulants and for ADHD. And the figures there, just an example, 8% of all boys, that's 1 in 12 of every American boy is currently on drugs for ADHD. And those particular figures are doubling every 10 years. So just moving over to the UK, similar, but we're behind you, as we often follow the United States in all bad things. And on this one, we're I shouldn't joke about it because it's not funny, but ADHD, for instance, in the United States, in the United Kingdom, by 2016, 105,000 of our children were on ADHD medicine. Just 5 years later, last year, it had gone up from 105,000 to 153,000. That's a remarkable acceleration. And a large study has just come out in the United Kingdom showing, unsurprisingly, that children and adults living in deprived areas are being medicated at 2 to 3 times the rate. So we're effectively, as well as all the things that Sami and everybody else has identified, we're effectively medicating the effects of poverty. And polypharmacy is increasing everywhere without any research whatsoever on the interaction of these drugs and the effects on the developing brain. I have to try and be balanced as chair. We have to acknowledge, I think, that some children and some families do benefit from the prescription of these drugs. How much of that is placebo, how much is the actual effect of the medication is debatable. But as we might get into when we broaden the discussion now, these drugs have many, many adverse effects. I don't think we should call them side effects. I'm only going to cite one. The average, the ADHD drugs, for every year that a child is on ADHD drugs, their physical growth is stunted by 1 centimeter. That's just one. I'm supposed to be the chair, so I'll stop there. But for those of you who weren't convinced, this is a massive, massive problem, and those numbers are all accelerating. With one exception, to be fair, the drugging of young children in Britain is actually coming down. The up to 5-year-old is actually decreasing a little bit, which is good news. I think the goal is probably to get them all to decrease quite a lot. But I'll shut up now and open it up to the panel and the sorts of things we're talking about, as we've begun to already, the expansion of diagnosis and drugging, and not only what you think might be causing that expansion and what the problems are with it, but also we need to talk about what needs to change to make things better. And if you have examples of good practice, as which I know you all do, please feel free to share those as well. So since I was rude to Mo and interrupted her, can we start with Mo again, if that's all right? And now it's a bit more free, so feel free to jump in, but I'll make sure you all get roughly the same amount of time. So back to you, Mo.
Just a couple of points, just to follow up. I know my story is very difficult to hear. I can assure you that I've always believed in, you take the lemon that life hands you and you squeeze it dry and you get that juice out of it and you use it for good. I happen to be in a position, maybe this is fortunate, that I see a lot of clients, a lot of people who are suffering. And my experiences have guided me to approach people differently and to help them to understand what is going on when they are being prescribed psychiatric drugs. And this includes also for their children. And this is kind of, an inner knowledge that I would not have otherwise have had. If I hadn't gone through what I went through, both of those experiences, I probably would be mimicking the safe, effective, non-addictive meme that so many people trained in traditional psychology is echoing. And so I'm in some ways, as strange as this sounds, grateful that this was able to cause a turn in my thinking and in the paradigm that I operate from. And I also, by the way, another thing that this has done, the withdrawal experience that I went through vicariously with somebody close to me, I see this with my clients. They walk in, they say, I stopped taking my antidepressant a week ago, and so far I'm feeling fine. And I have that knowledge and that, I have the warning label to present to them that I would never have had, I don't think, if I hadn't seen this up close and personal. So that's really just what I wanted to follow up on. So thank you for allowing me to do that.
So the rest of you just jump in now as you see fit, Sami.
Yeah, can I just wonder out loud about the question that you posed, or rather your attempt at being balanced, that you said that there are some medications that are helpful. I'm in the profession that is meant to be prescribing to children and young people. But I'm finding it increasingly hard, both in terms of my clinical experience as well as in terms of my understanding of literature, to find what benefits these are. So, for example, the SSRIs became popular as a prescription for so-called depression in children long before there was any of the studies that were done on them. When the studies have been done on them, and there is a very recent Cochrane review of the SSRIs and SNRIs, these are the newer antidepressants, so-called antidepressants in young people, which concluded that they, compared to the placebo pill, they have small and unimportant differences. In other words, nobody could tell that tiny difference. Now, when I was training, it was well known that the old-fashioned antidepressants wouldn't be used in children because the studies had not shown any effect. But also there was a very different way of thinking about depression. So if you go back to the psychiatry books that I was reading off when I was training in child psychiatry, childhood depression was thought of as a very rare thing, not treatable with medication, and usually the result of multiple adverse experiences. So that was, but now the concept has expanded, just in the same way that Laura was talking about how bipolar expanded, depression expanded as a concept in children, and with it came this idea that SSRIs might be effective. Now, in my clinical experience, and I have prescribed these, often before I understood what the evidence was, and since then, because I get a lot of, what can I call it, client demand for that, and I present the evidence, but sometimes that results in a prescription despite the evidence. But and I inherit quite a few people who've been put on these medications either by their primary doctor or other doctors. And universally, I struggle to think in my whole career of one person, and I'm being straight up honest here, I struggle to think of one person who has had a lasting benefit from taking these medications. I've come across plenty of people who seem to have had a period of improvement and it gradually tails off. And then, unfortunately, they're often into the area where then they're thinking they need a higher dose or another medication. And unfortunately, we're sort of funneling them down the potential pathway to becoming a long-term patient. In terms of stimulant, the other major group, the long-term studies show that not only are they associated with more likelihood of adverse effects, including the things related to weight and height, but also things like mood problems as they grow older. Not only are those increased in those who take stimulants compared to those who don't, but in addition, if you start looking at the outcomes after 3 years, 5 years, and so on, there's no difference between those who've taken stimulants, regardless of the original severity. And in the studies that do find differences, it tends to be better outcomes for those who didn't go down the route of medication.
If I may, It is sobering for me to hear Sami's thoughts. I would say I'm fairly skeptical of psychiatric medications, or at least how large their role generally is. But I do prescribe them, much less so than the average psychiatrist in Canada, but probably more than Sami does. And maybe in parts because I'm still relatively early in my career, but I've learned a lot from thinking critically about these things, reading about these things from people who have done critical work and written on these things critically, such as including Sami. But I don't know if maybe over time I might start being have my view being as negative as Sami's when it comes to these drugs. It might be. In terms of the use of these drugs, the way I see them is, and I tell this to patients and families. So first of all, in terms of the SSRIs, to use that as an example, I've been skeptical about these since early in my training. I came across a paper by Irving Kirsch, a study by the psychologist who's now at Harvard, who's done a lot of the pioneering studies comparing these medications to placebo and showing barely any effect. And I came across one of his papers very provocatively titled "The Emperor's New Drugs." I was very shaken up. I read the paper, and I would take it around with me, and I would ask different expert supervisors for their input. And what I was hoping for is that they reassure me and tell me why this was it could be ignored. It was a bad piece of work. But I could not get this reassurance. I got people were very defensive, and then so it just grew from there. When I prescribe these medications, I tell patients and families, I tell trainees, I tell other colleagues, I say they don't treat anything. And so I make it clear, these are not fixing. It's not like we know there's something specific in the brain that's off and these are going there and fixing it that way. Not at all. They don't treat anything. They're very crude tools. If we're lucky, they might give us some effect that we want and not give us very problematic effects. And this is a trial kind of thing. So, the most common effect that I would be looking for, it would be a bit of a blunting of the emotions. If the emotional intensity is so severe that the person is not able to function, they're overwhelmed, not able to engage in anything, then I hope that trying this as a crude tool helps with a bit of a blunting, knowing all the caveats that come with it and such. So this is the context I put whenever I prescribe these medications. And I say we're not looking here for any dramatic effects. If we get a huge effect, we'll take it, but that's not what we're aiming for. We're hoping that even just to help take the edge off. But this is not where the money is in terms of things get improving, and then we certainly don't stay on it indefinitely and all of that. And if it doesn't work, we don't. So the other thing is, it's if I'm seeing someone who's already been on these medications and has tried multiple medications and they haven't been working and such, I'm not going to prescribe it, no matter how much they insist. And I explain, it's not even just about the evidence. I'm fine to put the evidence aside and it's whatever works for you, but it's clear it hasn't been working. And now we're just really obviously causing more harm than good. This is completely counterproductive. We just continue pursuing down this route. So anyhow, this is the context I pursue when I use them much, much less than I should say. I use them very infrequently. But this is the context where I might try to use them. I'll pause here for now.
I'd love to take a stab at some of what I think is at the heart of why we have these epidemic rates of diagnosing and medicating in children. And I have to start really with, a critique of our schooling industry. And because when I think back on what it was that got me psychiatrized, it was at heart a profoundly wise, deep, intuitive response that I was having to an inhuman system that I was being funneled through. And because I was so young, I wasn't able to see that that's really what my very intense emotions were about. But of course, now, all these years later, it's clear as day to me. And I share this as someone who grew up, in a family of means. So I was sent to the top private schools in my town. I went to a top New England boarding school. I went to Harvard University. Like, I was the embodiment of a successful student attending the best schools out there. That was the model that mattered in the world I grew up in. And because I happened, for better or worse, to be good at doing school this way, which I should say is an incredibly modern phenomenon. This is a post-industrial model of education, this idea that we as young people are meant to sit in a chair and be talked to by adults who are essentially viewing us as empty vessels that they will fill with information that we're expected to kind of passively receive, maybe memorize, or maybe do some kind of shallow analysis of, and then give back in the way that the adults around us want to hear it. That's really what much of modern schooling does. And when I think back to who I was as a little kid, I was, lucky enough to live near nature. So I was in the woods, and my feet were in the grass, my hands were in the earth. I was learning through living and being. And I've come to believe that as human beings, especially as children, and now that I'm a mother, and it makes me cry, like, learning isn't meant to be about stripping you of your spirit and teaching you how to regurgitate information that's really aimed at helping you become a good producer and consumer in this, as Sami said, in this neoliberal, individualistic social order that we're now in. And so we can't really understand why so many children are being labeled and medicated until I think we understand what, just how far we've fallen from what it really means to be human and what it really means to be a child and a young person in the world. And I think about this every day with my son, who's now 8 months old, and I watch how he learns, and I feel so grateful. Mo, as you said, my years of hell in the mental health system, my suicide, everything I went through, I am so grateful for it, because and to anyone out there who's in that right now, it is a gift. Once you move through it, which you can and you will, it gives you it teaches you so many lessons about the life that matters, a life that's worth living and one that isn't. And I think we have to, as a society, and that's not even as a society, just in our own communities, within our family systems, within our neighborhoods, we have to step back and say, is this really how we want children to be growing up? Because had I had the wherewithal, which of course as a child I couldn't have had, or had there been a visible space to me of other young people who are basically coming together to say, this is fucked up. Why are we sitting here for 5 hours straight in a desk? Why do we care about an A on a piece of paper? Why does it matter if I can memorize X, Y, and Z? Like, I want to be outside learning about, the ocean. I want to be like, the fact that there wasn't a space for me to be questioning these structures I was in as a kid, I think is a big part of the problem. And that gets to the heart of what it is to be a child, that children are essentially, segregated from each other through adults. It's not often that there's a truly kid-only space. There are usually gatekeepers who are adults, whether they're teachers, parents, coaches. And I think the second adults are involved, as children, we feel that power. We feel, I can't say what I really think and feel. And so I'm eager to hear others' thoughts or commenters listening today about, how we can address this, because the rates are only going to keep going up as long as we separate what are very healthy responses to a completely dehumanizing system. As long as we separate those out and medicalize them and drug them, we're hooped, we're doomed. So thank you.
Yeah, I just piggyback, Laura, on that brilliant statement. And I'm just going to move up to the college years because I teach undergraduates. That's what I've done for 30 years now. And I've seen the evolution of normal psychology during that time. And it hasn't been much of an evolution, I'll tell you that. One thing my experiences did is it radically changed how I teach. Because these college students, especially this current generation now, this Gen Z, or whatever you want to call this generation, they're steeped in this stuff and they pretty much self-identify as having a mental illness. I mean, it's just rampant, as you probably know, just rampant. I mean, I have a young girl, I usually don't see younger adolescents, but I do see them from time to time, a 15-year-old. And the depth of her self-diagnosis and how screwed up she thinks she is because she is reacting to abnormal life circumstances, it's beyond the pale, okay? So I see this in my college students, and it like I said, it radicalized me. These kinds of experiences do radicalize you. And so I emphasize the sociocultural model. I emphasize, the ACEs, the trauma literature, the trauma-informed approach. And that makes so much more sense than this biological approach. And I'm hoping that I can just make a little tiny drop, in this change in the mentality. The other thing, of course, is what's available on the internet for these young people. And again, there's a lot of, pathologizing of symptoms and a lot of self-labeling and so on and so forth. So I think that plays a very important role in this whole picture.
Mo, you jumped ahead and said what essentially my same thoughts. And actually, when Sami introduced himself, I think he also ended with the statement along similar lines in terms of it being very sad for him to see young people coming today identifying. Listening to your story, Mo, in the introduction, and then Laura's story, it did hit me that your stories happened around 15 years ago. And I just felt, it hit me that today it's actually worse because whereas Laura went and she felt intimidated when someone told her there's something off in her brain, this is the diagnosis, this is the treatment. Today, it's not someone intimidating, it's you saying that. They completely drank the Kool-Aid. It is not uncommon. I'm going to describe a scenario, and I'm not exaggerating or caricaturizing, believe me. I'll see a young person in the emergency room who came in because they're suicidal. And I will ask, so why do you want to kill yourself? And they will say, because I'm depressed, because I've got depression, because I've got depression. So then I will use the term, how come you're feeling so sad? And the response is, I don't know, it's a chemical imbalance in my brain. Like, what kind of stupid, dumb question was that? So I joke around sometimes with trainees, if you need to review your diagnostic criteria, ask some of the young patients we're seeing, because they are so read up on this stuff. They've drank it in their schools and the whole mental health awareness, destigmatization campaigns that have sort of normalized, and there's been a romanticization. It's kind of like even a cool thing, unfortunately. And I'm not saying adolescents are not struggling. I do think there's an increase in struggles among young people today, and we can talk about that. But I think concurrently in the rise of struggles, it's a harder world, it's a more challenging world that we live in today. I think being an adolescent today is much more challenging than when I was an adolescent. And so it is a harder world, but at the same time, we have been feeding these young people and society as a whole that, as to use Sami's term, that this fear of emotions. In fact, this fear of emotions is so intense. I find it starts so early on today that even from very young kids, God forbid they experience any form of distress. We like, what's going on kind of thing. So there is an aversion to any expression of distress among kids. And as they grow, we deprive them also of opportunities to work with their emotions, to learn through them. and grow with them. And then as they hit adolescence, which is challenging in and of itself, and especially in this world of today, you map onto it the way we conceptualize distress and suffering today. And this is a chemical imbalance. And it's further been enhanced the last few years is social media. I don't want to just blame social media because I think it's too easy to just blame social media, but I do think it's had a powerful role in propagating these things. And so we find ourselves, so it's just because, I want to be hopeful, and I am hopeful actually, because I do think we can make things better. But it is sobering that, to hear Mo and Laura's personal stories that were from 15 years ago, awful experiences, and to think that it's actually worse today.
I'm going to jump in here because it's nearly time to move to the questions from the audience, so to speak, but we've got a few minutes left, and I'll put you all on the spot and give you 1 minute each, if you would. You've all very articulately described the problem, the extent of the problem, both scientifically, personally. We haven't really, I don't think, got to the question of why is it so bad? You touched on different aspects of it, but anybody brave enough to have a go at how did we get into this mess? So that might position us well to talk about what the solutions might be. It's a difficult question. I don't know the answer myself. So anybody want to have a stab at how we got into this mess in the first place?
Well, one aspect is direct-to-consumer advertising by the drug companies in the US and New Zealand.
Okay.
That's been a big part of the problem. Might not explain all of it, but that certainly explains some of it. Because now people go to their doctors and say, I want X drug.
I mean, Laura touched on as well some of the contributors, and I would go further in terms of, and this connects as well with what Mo is saying, that when we shifted as a system from what some people call welfare capitalism to what now we sometimes refer to as neoliberal or late capitalism, or whatever term you want to use, we've really shifted towards a very individualistic way of looking at our lives. And so we now have a set of ideas that on the one hand means that when we're experiencing distress, we imagine that it's something going on inside us. And in order to deal with that, we go to the market just like any other consumable. So, and I see this process as happening with the therapies just as much as it happens with the medications. Obviously, medications may well have a lot of worse long-term effects on the body, but it's a similar process. This idea that it's just like any other illness. It's something going on wrong inside me, and I can go to the marketplace, or I as a parent will look at my child and be concerned that they have a particular problem that needs an expert and needs a particular consumer product. So these days, what we call psychiatric diagnoses, they're not diagnoses in the medical sense, in that they don't refer to any cause. They are brands. So you will find that there are some very strong brands that grow in the marketplace. So anything to do with children and their behavior is a strong brand, and anything to do with adults and mood, anxiety, and questions about self-concepts, these are the strong brands. And these brands will develop a whole load of consumer products around them, including these snake oils that we call medication.
Okay, thanks, Sami. Elia or Laura, do you want to chip in?
I'll just quickly add to what Elia was saying a few minutes earlier, which is so important. This idea, and I can speak from firsthand experience of how almost romanticized these diagnoses have become for young people. And I think this was my experience when I eventually did give in and accept the diagnosis, and I made it who I was. It became something I was proud of, and I viewed it as this visible marker to the outside world of just the profound depth of my pain. Because no, I wasn't just human, just having struggles. I was sick. I was like physically, there was something wrong with me. And of course, what that really was about was, it's not my fault. You know, this, I've tried everything to feel better and it's just not working. And so, you know, by internalizing the sense of it's just faulty, you know, brain pathology, it absolves any sense of responsibility and onus on my shoulders. But I think what really is important in this is that we, as human beings living in this day and age that Sami just mapped out so clearly, we are all exhausted and wounded and afraid and scared and anxious and disconnected, whether it's the schooling system or just how meaningless so much of the 9-to-5 grind is for so many people, the debt, the student debt, the struggles people have to pay the bills. I mean, there is so much pain and so much wounding that has happened for children, for parents, for all people alike. And we are exhausted. People are exhausted. And when you are exhausted and desperate for something to help you understand why you're feeling this way, because I think this is part of the struggle, is that so many people don't see that this is why they're, you know, I'm so depressed in college. They're not saying, fuck this college system. They're saying, what's wrong with me? That is, I think, what makes that diagnosis just so enticing. And if we could find ways to repoliticize and recontextualize our individual experiences in this broader structural spiritual framework, I think it will help to make a dent in the rampantly increasing rates. I think it's a huge part of why the problem is what it is right now.
Thanks, Laura. Elia, very briefly.
Just everything, I think this been pretty well covered beautifully. I agree with what Sami and Laura have said about this. I want to highlight something that both of them touched on, Laura a little bit more. It's that we need to think about this broadly. You know, we're talking about children and adolescents, but what about the adults? You know, I think this is where, if the adults are struggling, is it whether it's parents and families and teachers, is it going to be a surprise that the kids are going to be struggling? You know, when you see, I'm going to leave with this question, is when you see the rising rates of suicidality that we've been seeing in recent years, in the past 5 to 10 years among adolescents, it should make us think, what is wrong with society when its new generation doesn't want the future that it owns, that it's supposed to own?
Okay, thank you all for that. I'm going to now move to questions from the floor, as they say. And the first one is very specifically to Elia and Sami. And several people have asked this in different ways. What sort of pressure do you get put under from your colleagues to prescribe and diagnose more than you do? And I'm going to add a second bit to that. What prevents more of your colleagues acting the way you do? So 2 parts to that question. Are you put under a lot of pressure, and how do you cope with that? And where's the rest of the gang?
Yes, you do get put under a lot of pressure, but I have to say, I think most of the pressure these days comes from the young people and their parents who are hoping for a diagnosis, and many of them are also hoping for a prescription. And to be honest, my life would be, as a practicing psychiatrist, would be so much easier if I just went along with that all the time. In terms of my colleague psychiatrists, I think I'm feeling a little bit more hopeful these days. For example, the Critical Psychiatry Network has a growing number of people, has a growing trainee base as well. The trainee child psychiatrists that I've come in contact with, and I've been a trainer for a few years, A lot of them seem to be a lot more thoughtful and interested, and they're kind of coming into child psychiatry because they're interested in getting away from a more medicalized approach. I had some nice feedback recently in a discussion I was having with our regional trainees after I circulated the recent Cochrane review that said that these antidepressants are not very, the differences between them and placebo are small and unimportant. And one of the trainees who did spend time with me as part of this discussion said, in my most recent placement, I seem to be prescribing these SSRIs for most of the young people I see. But when I was with Dr. Timimi, I only prescribed it to one person and she came off it. And to be honest, the outcomes don't seem to be that different. So there's a lot of people out there who, when they get a chance to do something in a different way, discover that actually it can work just as well.
And Elia, you're in a different continent, and I'm going to be bold and say a different generation. Sami won't mind me saying that. What's it like for you?
So I would say there's similarities with Sami, and the question, maybe there are differences in the extent of the pressures. I would say probably most of the pressure, similar to Sami, comes from society at large. So patients and families you're seeing. Interestingly, some of the most vocal opposition I've had experienced from people when I haven't prescribed came from social workers, a couple of examples I can think of. So this is how embedded our society is with these things. From colleagues, there is not as much direct pressure. There is some, but you have to. I think it depends on the micro environment you're working with. I have I have built relationships with the people I work with, but nevertheless, because we do have different views, I would say I get more frustrated with them than they do with me, because I see things like, if I have a patient with a diagnosis of ADHD and they're not on a stimulant medication, I'll see colleagues using the term that this patient has untreated ADHD, for example. And I find it frustrating when people use this term. It's like you're depriving this patient of something, or same with antidepressants. So there is some, I work a lot with trainees. Some of them are shocked when they first start working with me, but then they come around. I would say what gives me hope is the new generation, is the trainees, because I have to say I'm very impressed with a lot of the trainees that I meet these days. A lot of them are already thinking about these things. They've been exposed to these issues, and so that does give me some hope. The last bit I just want to share that is important is the regulatory bodies. So in Canada, these are the provinces. Each has their own regulatory body of how medicine should be practiced. And I do have a friend who's a practicing psychiatrist who got into trouble with our regulatory body because he referred to antidepressants as quote unquote souped up placebos with a patient, and then the regulatory body heard of this, and he got into some trouble with that. So these things do exist. I want to say the pressures are there, but it's something to navigate.
Okay, thank you both. Some of the questions that have been asked, I think you've already answered. For instance, a couple of people were asking, are we doing any better these days at helping adolescents learn about their emotions and learn to accept and understand their emotions? Certainly Laura thought the answer to that is no, and it's getting worse. So, if anything, so I'm going to move on to another question. If the chemical imbalance is defunct, and some psychiatrists say it is, and some say it isn't, what's the alternative? And I want to start with Mo and Laura this time.
So you are probably all aware, the panelists certainly are, maybe some people in the audience are aware of what Dr. Gabor Mate has said. He works predominantly with addicts in the Vancouver, British Columbia area, but I'm sure he's been also around the world, I would guess. One of the things he said is he never met an addict who did not have relatively significant childhood trauma. And so the trauma-based model, I think, is an excellent, at least an addendum, if not a substitute, for the traditional chemical imbalance theory. Who knows what trauma does to the brain? It does many different things to the brain and the central nervous system, and I leave that to the neurologically oriented folks here, but we know that it changes children's brains. And I have endless conversations with my clients about their childhood experiences. And in general, what I see is a correlation, at least, we can't say causation, but a correlation between the severity of childhood deprivation, adverse childhood experiences, and then later on, adolescent and adulthood psychopathology. So certainly the trauma-based model is very, very useful. And it's, at least in this country, it is very much gaining in ascendancy.
I'm not a huge fan of models generally because, I think often a model develops in order to be imposed in an umbrella kind of way over a large collection of people. And right then and there, it means you're going to lose the context. You're going to lose the subjective. You're going to lose the story. But what I'd say has been incredibly transformative for me in my own life, and I guess you'd say it's more of a practice. It's to question everything. I now, whatever it is that I'm reading or being told, whatever it is that I'm feeling or thinking about myself or about the world, I do my best to step back, to step outside of it, and to ask, where did I learn this from? What forces, what entities perhaps influence me to think this thing that I'm thinking or believing or feeling? And so I would be especially excited to see more of this practice happening rather than us say, because of course, trauma is I'm a big fan of Gabor Mate. I like to call him Gabor for some reason, even though I've never met him before. And there are many models that ring true for many people, but I would caution us to just replace the medical model with something else. And instead, I think it is about stepping back to unpack how we think, how we learn, how we believe. And then each of us in our own individual contexts within this bigger socioeconomic political context can come up with a framework that makes sense for us, for each of us.
Okay. I think okay, Sami, if you can be brief, and I'll take us to the next question. Go ahead.
Okay, yeah. No, I wanted to follow up on what Laura says, because I do have a concern about trauma getting reified in the same way that chemical imbalance might get reified. So I do understand that the literature says that there is an association between greater adverse experiences and subsequent what we're thinking of in terms of being a psychiatric disorder. But one of the things that has really, I think I've really understood increasingly the longer I've been in this game and looked at different models and tried to get my head around the different ways of thinking about it, is that what we think of as the mind or the psyche or the soul, depending on your frame of reference, is a big black box where we don't really know what the hell happens. There's only a few things we can say with any certainty about it. One of the things that we can say is that it's a meaning-making organ, that we try and make meaningful sense of our experiences. So what I tend to think of is that we have models with consequences. Some models are worse than others, rather than some models are better than others. The medical model is probably the worst one you can think of to make sense of your experiences, because it's a cultural model of emotions that, as I say, alienates you from that.
Thanks, Sami. I'm gonna take us to our last question, but it's really an amalgamation of questions that people have asked this in many different ways, and it's probably the most important question. And that is, what are we going to have to do to create change to stop all this harm, both at a meta level, systems level, and what can each of us as individuals, either professionals or service users or mums or dads or whatever, what do we need to do to bring about that change? So what do we need to do and how do we do it?
Can I start?
That's it. Yes, by all means.
A few months ago, a psychiatrist in the critical psychiatry network called Dr. Bracken, who's been involved with the World Health Organization, who produced a recent new package around how to develop community mental health services. And he's been involved in some of their research, looking at different examples around the world of different models. And he said something very interesting, which has got me thinking that, and wondering about the potential for change. He said that when the Critical Psychiatry Network was first founded back in 1999, we were the marginal area in mental health practice. But now, actually, things have been slowly shifting in all sorts of ways. And now it's mainstream psychiatry who is the ones being left behind. Because I think that the chemical imbalance, narrow biomedical model is being rejected left, right, and center. So when I think about the people I work with and have worked with, the opinions that I have, I would say, is much closer to the majority of opinion amongst the therapists, the psychologists, and the nurses that I work with. And actually, even though the psychiatrists have most of the power, it seems to me that we don't know when that moment of potential critical mass will come. Often rapid change happens at unexpected moments. If you look at a lot of things where, you know, revolutions have happened or big political changes have happened, that they've often happened in surprising ways and quite rapidly, because underneath there has been a critical mass that has been building up. So I think it is partly about carrying on doing what we're doing. Hopefully what is shifting in the professional sphere now will eventually start shifting in the public sphere too.
Thanks, Sami.
It's nice to hear from Sami this this hopeful vision, and I definitely, for me, as I said, it's more the new generation. I can't say it's been my experience that the critical psychiatry is, or views that are aligned with critical psychiatry are the majority now. It might be because I live and practice in North America. But it is true that I am increasingly seeing younger trainees who have critical views. And I think this is key here, and Laura touched on it, is about questioning everything. We like to have answers, and as whoever famous person said, for every complex problem, there's an answer that's clear, simple, and wrong. And so I think it's learning to ask difficult questions and not shy away from them, and becoming comfortable with uncertainty and having doubt and being able to work with that, because that keeps us on our toes. It keeps us thinking about different ways of viewing things as opposed to getting too closely wedded to a single model. So I think this is it's important for trainees to be able to do that. And I think it's important as a society, as much as we can, we need to undo some of the harms that have been done and that continue to be done in terms of the sale of this medical model. And I have to say, much of it is with good intentions. Most of our psychiatric, I would say the vast majority, almost everyone who's a prescriber or who has consternation about, because if one of us is not prescribing, it's coming from the best of intentions, and we want to remember that. And I try to remind myself always the importance of thinking that way and working with people individually, building relationships. And what we do as individuals is key. But it's also broader than that, and I think we touched on a number of the problems in society that are going on in terms of socioeconomic policies that are the neoliberal policies and such, and direct to consumer advertising, all these things, and I think it is important that this be revisited. Our diagnostic models, the dominance of the DSM and such. One thing that I hope this will be an opportunity is the pandemic that's occurred over the past year. We've seen massive increases of people struggling emotionally in all sorts of ways. And I think it becomes increasingly ridiculous to just label them all as having one mental illness or another, when it's so blatantly obvious this is a result of some massive social problems, and that we need to address things that way. And the other thing that's happened over the past year, and I'll be done soon, John, the other thing that's happened in the past year is we've seen massive spending in public spending in the countries that can afford to do so. So hopefully this also tells us that we are able to do this. We are able to invest more in the public good and see what we can do to improve society that way. So I'm hoping that the pandemic, maybe as challenging as it's been, can present us with an opportunity to revisit the way that we've been doing things and to see that it is possible to do things differently.
And finally, to Laura and Mo.
I would say that one of the things that I spend a lot of time doing with my patients, my clients, is helping them to understand what is being done to them and what has been done to them, and to realize it is not their fault that they live in a society that does not support human needs. And of course, I echo what Elia and Sami are saying, and Laura too, that we need to change society. The other piece is that in another part of my professional life, I do some work in social emotional learning for children. And one of the things I recognize so much from my practice working with people, and I'm so privileged to do that because I learn so much from people and what they tell me and their suffering, is we don't learn how to access our emotions. We don't learn how to express our emotions. We're not given that permission. We're supposed to be stalwart and we're supposed to hold on to things. And so people are trained not to be in touch with themselves. And so many people don't even realize that. And so to help people to realize that their human potential, what is their human potential? What does it mean to be a human being? And to give them permission to be fully human beings. And obviously that's a very tall order, and we need to change our whole culture around that. And we also need to change the perverse incentives that are so predominant in our society now, such as what we see with the power of the drug companies and the commercialization of mental illness.
So as it happens, Laura, you're going to get the last word.
Okay. Yeah, I think it can be really overwhelming and hopelessness inducing to think about how much needs to change as Mo and everyone else has touched on, at these institutional structural levels where profit motive drives so many of these decisions. And in my opinion, when it comes to the well-being of individuals and society as a whole, if profit is involved, chances are it's not really going to be about well-being. So it's easy to get spun out and to say, well, all of the lobbying industry here in the US, the pharmaceutical companies running everything, what can we do? What gets me really excited is thinking about, it's just getting to the grassroots, literally thinking about each of us in our own lives, in our own neighborhoods and communities, reconnecting with what I think we've lost touch with, beginning, 60, 70 years ago, just the power of community, of true grassroots, mutual aid communities. And when you realize how much you have in you to, as Mo said, to be with yourself, which of course in the consumerist era is very radical, to just be with yourself, to not check out, to not seek relief. And when you realize how much power you have to be with your pain, and when you realize how much power you have to be with someone else in pain, then suddenly that urgency to like, let's go to the crisis center, let's make an extra appointment with the doctor, it lessens, because you see you actually have this power in you. And I think we need to reclaim that and find ways, because if you think too big, it's immobilizing and then you don't do anything. But if you think literally in your own community, what you can do with one family on your street, to support them, have them support you, that's how I think true lasting change will take hold, is if in our day-to-day lives, we step up for ourselves and each other and think small, because that will have big effects.
Thank you, Laura. So what you're not aware of, probably the panelists, because you've been too busy thinking and listening to one another, is there's been equally wonderful parallel discussion going on in the chat, as happens in these situations. So while you were all discussing what needs to change, somebody chipped in with, well, the first thing we need to do, of course, is stop asking people what's wrong with them and ask them what happened to them, and I would add, and what they need. So that's just a contribution from the floor there. So it falls to me to draw this together. Thank everybody involved, the wonderful panelists. Thank you for your honesty and sharing what you've been through, both personally and professionally. Thank you for everybody who's attended. It has been overwhelming at times, I think. Please be aware of all the resources that are available, including Laura's wonderful website in a compass, but so many others as well that are listed there. And for you parents, remember there's a parent resource on MAD in America. There will be more of these. This is part of an ongoing series, and they will be advertised on MAD in America. And finally, thanks again to James and Lucy for bringing us all together. So I find inspiration and feeling of positiveness and hope that the fact that we have all come together, not just the 5 that I can see in front of me, but the 150, I think up to 170, and the thousands that will see the recording of this, taking the time to listen and get involved and share their thoughts. So thanks to everybody involved. I've really enjoyed it. Thanks.
Thank you.
Bye-bye.
Thank you.
Bye, everyone.
Thank you, everyone. Bye-bye.
Bye-bye.
Thank you, everyone. Lovely to do this. Bye-bye.